This conference will now be recorded.
Good morning, all of you. So today we'll discuss about stages of labor. I'm sure you've had this class before also, but this is very, very basic, and we want all of you to know stages of labor without fail before we go forward to abnormalities in labor or any malpresentations or anything. So this is one of the basic things every one of you should know. So as you know, the stages of labor are four. Labor itself is the start of a painful uterine contraction accompanied by one of the following, that is rupture of the membranes or a bloody show or a complete cervical effacement. That is when we call a beginning of labor. So if another patient comes with any pains, you must be able to make out whether it is really labor or it is any other non-specific thing. So whenever there are uterine contractions, painful uterine contractions associated with any of these, either the membrane rupture and there's leaking of liquor, or a passage of the bloody show, or a cervical effacement. That is what we say it's a beginning of labor. Right. Now, how many stages do we have? There are 4 stages of labor. The first stage is the stage of cervical dilatation. As you know, throughout pregnancy, the uterus is passive. The baby is growing inside. It is covered with membranes, what are called chorion and amnion, and inside it you have the amniotic fluid. So the baby is floating in this amniotic fluid, and the cervix is closed so that it is preventive, protective, and there can be no ascent of any organisms, or the baby can come out. Now, once the labor starts, the idea is the baby has to come out, the cervix will open up. So during the first stage of labor, the cervix, which was hitherto closed, will totally open up to full cervical dilatation. So from 0 to 10 centimeters, that is the full cervical dilatation. That means there will be no cervix obstructing the passage. Now the uterus becomes continuous with the vagina. So all the baby has to do in the second stage is come out. So the second stage is the stage of delivery of the baby. Now it actually isn't as easy as it seems that the uterus is continuous with the vagina. So an ideal thing would be you make the patient stand and the baby would simply fall down. Now it isn't so easy because the space available is so small. The baby has to negotiate through the vagina and the pelvic cavity to come out. So the second stage involves a lot of cardinal movements, which is called mechanism of labor, which is a separate class. We'll teach you that, in which these movements will finally bring about the delivery of the baby. Now, once the baby is out, you clamp the cord, cut in between, and separate the baby and hand over to the pediatrician. Now, what is left behind inside is the placenta with the umbilical cord. And of course, the membranes have ruptured. So all that is left is to expel the placenta. So in the third stage, you have the stage of separation and expulsion of placenta. The placenta, which is still inside, has to separate from its attachment to the uterine wall, and then it gets expelled. Now, once the placenta is also expelled, what's left inside? Nothing. So there is no products of conception still left inside. So the fourth stage involves the stage of hemostasis. This is the stage when we are just observing the patient, because the placenta has separated. Until now, the placenta was in attachment to the uterine wall, and the vessels were passing from the placenta to the uterine wall. That is how the supply was coming, isn't it? So the baby, the blood supply was coming from the uterine wall to the placenta. Now, when the placenta separates, the walls, all the vessels will be open and they will be bleeding. So if it were to be left like that, every mother would be bleeding to death. So since it cannot happen such a way, you have to have something which will stop the bleeding. And that is what we call hemostasis. So this fourth stage is securing hemostasis, and you have to make sure every woman will have a stoppage of bleeding. So this is a stage of observation. Right. Now coming to details of each stage. The first stage of labor is from the onset of labor pains, true labor pains, till the cervix is fully dilated. So as you can see here, in the initial phase, the cervix is closed. The baby is inside and cervix is closed. So if the baby has to come out, the cervix has to open up. So here, the cervix is open, totally flattened, and the baby can come out. That is a full dilatation. Now coming to what are all the events that happen in the first stage of labor. The onset of uterine contractions or true labor pains, leading to cervical effacement, cervical dilatation, a passage of a mucosanguineous discharge, what we call show, formation of bag of membranes, and rupture of membranes. So coming to each of this, now obviously when the pains have started, you know the uterus is contracting, it's a muscle. It's a very strong muscle with crisscross arrangements of fibers. When the uterus contracts, what happens is the contents will be compressed. Obviously the intrauterine pressure increases. So the baby will try to come out through the area of least resistance. And which is the site of least resistance? It is the cervix. So it will come through the cervix. Now for that, the cervix is closed. So the cervix has a particular length and it is closed. So effacement is nothing but the shortening of the cervix. The cervix, which is about 1 inch long, will become shorter and shorter and shorter. So where does it disappear? Where is it? How is it becoming shorter? So actually, as the uterus contracts, it is pulling the cervix itself into its lower uterine segment. So you know that the uterus has an upper segment and a lower uterine segment. So a lower uterine segment is that part which later on forms an area where you do a cesarean section. If you've got a lower segment cesarean section. So that part of the uterus, it pulls the cervix into itself. So that causes the cervix to become smaller and smaller, and that's what we call effacement. And simultaneously, the cervix also dilates. That means it opens up. So initially, it will be say closed, then it will allow one finger dilatation, that is what we call 1 centimeter. Then it opens up more and more and more until it is fully dilated. That means full dilatation where you cannot feel the cervix at all. It doesn't exist. So that is full dilatation of cervix. Now, until now, the baby was surrounded with membranes and amniotic fluid. Now, once the cervix is dilated, there is nothing to support that. Whatever is inside the cervical canal. What is inside the cervical canal? A mucus plug. Between the internal os and external os of the cervix, there is a mucoid discharge because it is, after all, the cervical mucus glands will be secreting mucus into the cervical canal. Now, once the cervix opens up, that mucus plug can no longer be there. It just gets expelled. And because the cervix is very vascular, it may be blood stained. So this blood stained mucosanguineous discharge is what we call show. So when a patient says she's having abdominal pain and she's passing some mucoid bloody discharge, you know patient has gone into labor. Right. Now once the mucus is shed and cervix is fully open, what will happen? The membranes which were so far protected and supported will no longer have a support. So they will form a bag of membranes, unsupported bag of membranes filled with liquor. Now, a few more contractions and increased intra-abdominal pressure can lead to rupture of membranes. The membranes will rupture and it causes leaking of the liquor. So that is the end of first stage of labor. That is full cervical dilatation with rupture of membranes. So how about the uterine contractions? I said true labor pains or typical uterine contractions. Each of these contractions will have a fundal dominance. That means they start at the fundus of the uterus near the cornua and they spread downwards. The maximum intensity and force of contraction is at the fourth fundus and proceeds downwards. That helps in the baby downwards. And the duration of each contraction lasts for about 45 seconds. A persistent contraction for 45 seconds. Only then it is effective enough in pushing the baby down. Now, because of this, you know that the uterus contracts, but you have to remember that the uterus has got two segments, an upper segment and lower segment, as I told you. So the upper segment of the uterus is typically made up of the body of the fundus and the rest of the main body, which is responsible for contraction, retraction. So each contraction, the uterus will become smaller, and when it relaxes, it does not come back to the original size. There is still a slight amount of contraction left. So this thick and muscular upper segment, like this is the upper segment. This will contract and retract, contract and retract. And it will push the baby downwards because each time it relaxes, it does not regain back to its original size. It is still a little smaller than the previous size. So the baby will be pushed further and further down. Now the lower segment is the lower part. Here, this part is formed by the isthmus and the cervical region, about 8 to 10 centimeters in length. And this is only going to take the part of the baby which is coming here. It is receptive relaxation. It only distends and dilates, and it just receives the baby which comes. It does not contract. So this upper segment is very muscular, strong contractions, which pushes the baby down into the lower segment. This lower segment is receptive relaxation. It just dilates and distends and accepts whatever is coming there. That's the two parts. Now coming to the differences between true labor and false labor. Now, how will you discern that this is true labor? Patient has come with pains. It could be anything. So if you have to know that this is typically true labor pains, what are the features which are suggested? And so you know that this is true labor. You have to sit by the patient, monitor her and deliver her. If it's false labor, you're wasting your time. Suppose you plan to go for a movie with your friends and it is false labor. You have cancelled your movie trip. You're sitting with the patient. Even if you sit all day, that baby is not going to come down an inch. So you must be sure that the pains that the patient is complaining of is actually true labor pains. So how do you ascertain? Typically, the nature of pains, or rather true labor pains, are progressive in nature. Progressive in frequency, intensity, duration. Frequency means initially it might be occurring like say once in an hour, then once in half an hour, once in 10 minutes, then say 2 times in 10 minutes, thrice in 10. That is more and more frequent. Then intensity goes on increasing. That means initially the pain was mild, then more severe, and more severe. So the severity increases. Typically also the duration of contraction. That means initially the contraction may be for 10 seconds, then 20 seconds, then 30, maximum use as I told you 45 seconds. So true labor pains are progressive in nature in terms of frequency, intensity, and duration. Next, very importantly, if these are true labor pains, they will definitely cause cervical effacement and dilatation. That means the opening of the cervix, which is called dilatation, and the shortening of the cervix, which is cervical effacement. So how is it becoming shorter? The cervix is being taken up by this uterine contraction, which is pulling it up into itself. Cervix gets pulled up into the lower uterine segment. So it becomes shorter and shorter and shorter, finally it disappears, becomes papery thin. And also it opens up. So cervical effacement and dilatation. If you find those two things on doing a vaginal examination, you know this is true labor pains. Now the third important point is, if you give them a sedation, a false labor pain will simply subside, whereas a true labor pain is not going to get affected and subside in the active phase of labor. Also enema, if you give an enema, if it's false labor, it will subside. Whereas in true labor, nothing is going to stop it, neither sedation nor enema. And more effectively, the most important thing is, whenever there is true labor pain, you will find progressive descent of the fetus. It will be coming further and further down. Whereas in case of false labor pains, there will be no change in the position of the fetus. It will be lying where it is, that's all. No effect on the baby. It's just here and there, irregular contractions without any change on the cervix or the fetal descent. And simply you give them sedation, patient nicely sleep. Nothing will be there. Okay. So that is very important to identify what are true labor pains. Next, I told you that true labor pains will be associated with effacement. So effacement is thinning of the cervix. So you can see here, the cervix is so long here, then it becomes shorter, and finally it disappears. It becomes very, very thin. There is no cervix left. There is no substance of cervix. That is effacement. Right. Now cervical dilatation. It is a process of enlargement of the os of the uterus from a tightly closed aperture to a large opening enough to permit the passage of head. Imagine here, you can see that the cervix is closed. Here the cervix, this is cervical canal, and the cervix is closed, the baby is above. Now once the dilatation starts, you can see it's opening up. It can allow, say, 1 finger, it's called 1 centimeter. Then it is going on increasingly opening up, 5 centimeters. Finally, the whole of the cervix opens up. There is no more cervix. So the uterine wall is in continuity with the vagina. Okay. So this is progressive cervical dilatation. So you can see that it starts from 0 to 10 centimeters, which is full dilatation of the cervix. Now this cervical dilatation is divided into 2 phases, a latent phase and active phase. So the latent phase, the duration is variable and it is associated with very slow or little minimal cervical dilatation. Okay, in the early part. Later on, there's active phase of cervical dilatation, which is very accelerated, very fast. It dilates very fast. There's a phase of maximum slope, and then of course it decelerates. It becomes slow, the last part. So this is the 2 phases of cervical dilatation. Now, one other thing we said, once the cervix dilates, the cervical canal, which contains the mucus plug, it gets expelled. Because once it opens up, it can no longer stay in place. What will happen? It will just come out. And because the cervix is very vascular, it becomes slightly blood-stained. So you can see here, it's a blood-stained mucoid discharge. Just at the beginning of labor, a small amount is this red tinged mucus may be passed. If patient gives you this history, you all know that patient's cervix is dilating. Okay, now once the cervix is opened up, what will happen? There is no support for the baby's head. So the membranes are surrounding it and it forms a bag of membranes. And this liquor will be in this bag of membranes. A little more contractions, more and more contractions will increase the intrauterine pressure. And this membranes are very thin, chorion and amnion. They will rupture and there will be release of amniotic fluid. So there's a gush of this amniotic fluid, which is normally colorless. Okay. So this is the end of first stage of labor. The duration of first stage of labor is, in a primigravida, it is 12 hours. In a multigravida, who is more experienced, previously had deliveries. So, you know, whenever we have more experience in doing anything, we'll do faster, isn't it? So, here also multigravidas, they can finish this first stage of labor in 5 to 6 hours. They're more experienced. So, To repeat, the first stage of labor starts with the onset of true labor pains, which are progressive in frequency, duration, and intensity. They lead to cervical effacement and dilatation. They lead to expulsion of the cervical mucus plug, which is called show. Then there is formation of a bag of membranes and rupture of membranes. All this takes about 12 hours in priming, 5 to 6 hours in multi. Now, once the cervix is fully dilated, no membranes are there, the baby is open to come out. So that the next stage is the delivery of the baby. So second stage starts with the cervix having reached full dilatation and ends with expulsion of the baby. So as you can see that the cervix is open and all that the baby has to do is come out. So what are all the things that are occurring in the second stage? The nature of uterine contractions become very strong. Now once cervix is fully dilated, all that is happening is baby has to come out. So the uterus will be trying to push more and more faster, and we call this bearing down. When the voluntary muscles also begin to contract, that means the mother also contracts her abdominal muscles and tries to push. That means the uterus will contract spontaneously. We cannot influence the uterine contractions, but we can cause contractions of the abdominal muscles. So the fetus is pushed down through the dilated cervical canal, and once it reaches the perineum, when the head reaches the perineum, it stretches the perineum, and stage comes when it will distend the perineum and not recede back. That stage is called crowning. And finally, it passes out of the outlet. That is the delivery of the head. So you can see here there are a lot of cardinal movements of the fetus: engagement, descent, flexion, internal rotation, extension, restitution, external rotation. All these movements are called the cardinal movements of the fetus, which help in bringing about expulsion of the baby. So these steps are actually a separate. I will tell you each of these a little in detail. So engagement is basically when the greatest diameter of the fetal head passes through the brim of the pelvis. So this you can see is the brim of the pelvis. The largest diameter of the fetal head is the biparietal diameter, 9.5 centimeters. Between the two parietal bones, this part enters the pelvic brim. The brim is the inlet. So that once it crosses the pelvic brim, it is called engagement. Next step is the descent. With each contraction, there will be further descent of the baby's head. There will be, and you can see the station -3, -2, -1, 0. 0 is at the ischial spine. Then as it comes out, +1, +2, +3. So the baby is coming at 0 station is when it is engaged. When the head has the lowermost point of the fetal head has reached the 0 station, it is called engagement. Now descent occurs when there is no CPT, when there is no disproportion. The pelvis is adequate. The head will nicely descend deeply into the pelvis throughout the process of labor. With each contraction, it goes further and further. So engagement, descent, then flexion. So here the baby flexes upon itself. That is, the head will flex upon the chest. Why so? Because this will bring the smaller diameters towards the pelvic outlet, and that makes it easier for the baby to come. So here the chin is getting into contact with the thorax. You can see the chin is bending and coming in contact with the thorax. As a result of which the presenting diameter, which was occipitofrontal. This is occiput, this is frontal. So that was actually here like this. Because of the flexion, it has come up, and now the presenting diameter will be suboccipito. Here the suboccipito bregmatic. That is smaller. This is 9.5 centimeters. So you know that because of good flexion, the diameter of the head which is presenting becomes smaller. That makes it easy. It facilitates easy expulsion of the baby. So engagement, descent, flexion. Now, as the baby has to come out, you know that at the inlet is transversely oval. Now, as it comes down, the pelvic shape changes and its outlet is anteroposteriorly oval. So the head, if it continues like that, it gets stuck. So it has to undergo internal rotation. So it turns in such a way that its larger diameter is in the anteroposterior direction. It brings the diameter of the engagement into a from transverse or oblique to anteroposterior direction. So this is the anteroposterior direction. So the head has undergone internal rotation. So you can see here it was transverse. Now it has undergone rotation and come into the anteroposterior direction. Now, once it has reached that stage, if the head has to come out, it has to undergo what is called extension. Initially, the chin was well flexed. You saw the chin was well flexed. Now, if it undergoes extension, the head will come out. This process is called extension. It results due to two forces. One is because of the uterine contraction. The uterus is contracting and causing the head to extend. Also, below, there is the elastic resistance of the pelvic floor. It's resisting. So both of these together, contraction of the uterus and resistance of the pelvic floor, lead to an extension of the fetal head. Now, once the fetus comes out, the head comes out, that internal rotation that had taken place inside, that caused a twist on the neck, isn't it? That when it underwent internal rotation, that neck gets untwisted. And this untwisting is called restitution. So the anteroposterior dimension, the head had gone into the anteroposterior dimension, now it comes out and restitutes, gets back to its original direction. So it resumes its original normal relationship and with the shoulders at its original position, pelvis. So the twist that was there on the neck gets untwisted. That's called restitution. Now the shoulders are in the oblique direction. Now the shoulders have to come out. The head has come out, the shoulders have to come out. If the shoulders have to come out, the shoulders have to align themselves in the anteroposterior direction. Unless they're in the anteroposterior direction, they will not come out because the anteroposterior dimension is the longer one. So if the shoulders have to come in the anteroposterior direction, they have to undergo rotation. That is internal rotation of the shoulders. But because the shoulders are associated with the head, when the shoulders rotate inside, the head will rotate outside. That's called external rotation of the head. The purpose is internal rotation of shoulders. So it's the internal rotation of shoulders with external rotation of the head because they're two attached. So if this undergoes rotation, the head will also undergo rotation. This is external rotation. This is internal rotation. They're occurring together. Now this brings the shoulders in the anteroposterior direction. Once this has occurred, the posterior shoulder will be delivered first because the baby undergoes lateral flexion. Once it flexes here, what will happen? This will come down. So the posterior shoulder is born first, then lateral flexion in the opposite direction leads to delivery of the anterior shoulder. So posterior shoulder expels, followed by anterior shoulder. And once the shoulders come out, the whole thing comes out. The rest of it is the abdomen and the lower limbs, which are very small. So they just slip out of the pelvic cavity. The main thing is the delivery of the head, followed with delivery of the shoulders. So this whole process, the second stage of labor, where all the different parts of the body come out, takes about 1 to 2 hours in a primigravida, and in a multi about 1 hour to 1, little less. So the cervix is fully dilated. All the baby has to do is come out of the pelvis. So it's going to come out through the different cardinal movements. So it got engaged, continued to descend, underwent flexion so that the chin bends onto the thorax and the smallest diameter presents. Then it undergoes internal rotation so that it comes into the anteroposterior direction, extends its head, comes out. The head has come out of the pelvic cavity. It untwists by what is called restitution. Then the shoulders come into the anteroposterior direction by internal rotation, which is seen outside as external rotation of the head. And once the shoulders come out by lateral flexion, that is the posterior shoulder comes out first, then the anterior shoulder. So that is the end of the delivery because once the shoulders come out, the rest of the body, that is the abdomen and the limbs will just come out. That is the stage of expulsion. Right. So once it has finished, once the baby has come out, you clamp the umbilical cord in two sides and cut in between. So the umbilical cord is cut, the two clamps, and you hand over the baby to the pediatrician. Now you have to take care of what is left inside the uterus. Now what is left inside the uterus? The membranes have ruptured, amniotic fluid has come out, the baby has come out. So what is left? Only the placenta with the cord. So this is the onset of third stage with the delivery of the child and ends with expulsion of placenta. Because all that is inside is the placenta with the cord. It's left like this because you clamped here and you separated the baby. So now the two things that the placenta has to do is it is attached to the uterine wall. It has to separate from the uterine wall and it has to get expelled. So there are two steps: separation from the uterine wall, expulsion. So that what are the things that are happening in the third stage? That again a fresh bout of uterine contraction start because separation of the placenta, because expulsion of the placenta, and once the placenta is expelled, the control of hemorrhage, the bleeding has to stop by a permanent contraction and retraction of the uterus. Because nothing else is there now. The uterus has nicely, strongly contract and retract so that the bleeding will stop. So what are the signs that the placenta has separated? So once the placenta starts separating, the vessels will open up. The uterus is contracting, whereas the placenta is not contracting. So there will be a shearing force between the two. And the vessels will open up and there will be a fresh bout of bleeding. Next, because the blood collects between the placenta and the fundus, there will be a rise in fundal height. There will be a slight rise in fundal height. When the whole of the placenta gets separated, more and more placenta gets separated, it falls into the lower uterine segment, and that is seen as a suprapubic bulge. The suprapubic bulge, and when the placenta falls down, along with it, the cord also comes further down. So when you're seeing the patient, you're at the foot end of the patient, you will find that the cord is lengthening. So it's an apparent lengthening of the cord. Obviously, it's not growing because the placenta has fallen down. The cord will lengthen. That tells you very important. Right. So what are the methods of placental expulsion? One is the placenta will separate by the Duncan's method. The other is by the Schultz method. So here, this is the placenta. You can see that the placenta will fold on itself. The placenta may fold on itself so that the long axis of placenta corresponds to the long axis of the uterus. So it is coming along the uterine wall. So the lateral end of the placenta is seen first. So it comes out like this. So what is seen? The maternal surface. So this is the maternal surface, this is the fetal surface. The fetal surface is covered with membranes. So it will be nice and shiny. But the maternal surface is filled with cotyledons. So these cotyledons will be very dirty looking. So it's called dirty Duncan's method, where it is separating from the lateral end. Lateral end of the placenta is separating first. The other is Schultz method. So here see, look at the placenta. The center of the placenta separates first. So it gets inverted. Here you can see this collection of blood. This is your placenta. And as it is coming out, the blood is seeping in here. So it forms an inverted umbrella. Can you see this? It's an inverted umbrella. So what is coming out is the shiny surface, the fetal surface. So it is the shiny surface out. It comes out first. So just as a mnemonic, we remember shiny Schultz and dirty Duncans. So the placenta will separate at the center. A retroplacental hematoma will form, and it leads to more and more separation with each uterine contraction. So once the placenta has come out, you have to examine the placenta in your hand. Make sure all the cotyledons are there. So you can, that towards the maternal surface, there are these cotyledons. All these cotyledons should be intact. Otherwise, suppose there is a gap there, what does it mean? That cotyledon is missing and it is present inside the uterus. That can lead to complete contraction of the uterine structure, and that retained bit of placenta can lead to uncontrolled hemorrhage. So you have to make sure the placenta has come out in toto. So what is the duration of third stage of labor? Whether in primary or multi, here it takes about 15 minutes. So once the placenta separates and expels, it's about 15 minutes. Right. Now once this is, now placenta has also come out, membranes have come out, the cord is out. What is left inside? Nothing. Nothing is there inside. Only the raw surface where the placenta was attached to the uterus. There the vessels which have separated that opened up and they're going to bleed, the site of placental attachment. So this bleeding has to stop. If it doesn't stop and continues to bleed, the mother will go into shock. That would lead to maternal death in every mother who will deliver. So there has to be a way that the bleeding will come to control. In other words, fourth stage is a stage of hemostasis. Whatever bleeding has been occurring, it has to come to a stop. And this is the stage when we are going to observe, because you have to make sure that the bleeding stops and it doesn't land up with postpartum hemorrhage. So it begins with the delivery of the expulsion of the placenta, after the end of placental expulsion, and lasts for 1 to 2 hours. And it includes the stage of observation. What are you observing? You're observing for any unnecessary bleeding. You're observing for the vital signs. What are the signs? Any hypotension, any tachycardia, which are the subtle signs of shock. So you will be observing the mother and you will see whether there is control of that. Now, what are all the methods by which hemorrhage gets controlled? So the various methods by which the uterus stops the bleeding is, most importantly, first, contraction of the uterus. You know that the uterus is a very nice muscular organ and the muscles are arranged in a crisscross pattern. So what happens whenever you have this crisscross pattern, any vessels which are passing through it, see, that will get compressed. If the vessel contracts, the vessel will get compressed. So here the vessels passing through it, if this contracts, it compresses the vessel. So a strong uterine contraction is required, and that is called living ligages. So that is the first most important method of securing hemostasis. Secondly, the vessels will undergo spontaneous vasospasm. That means they will contract and intrinsically they will undergo vasospasm. It is a protective mechanism. Third, the platelet plaques will form. The coagulation cascade is stimulated, and whenever there is an injury to a vessel, the coagulation system gets stimulated and it sends various factors which result in formation of a platelet. So the open vessels will be blocked by the platelet plaques. And fourth, the walls of the uterus will oppose each other. The opposition of the uterine walls, the anterior posterior walls will be firmly opposing each other so that there is no space for the blood to collect. Space. So if there is a big cavity, the blood will go on collecting. But when there is no space, what will happen? There can be no place for collection of blood. So all these four things together bring about an excellent hemostasis. It is well contracted uterus, spontaneous vasospasm of the vessels, platelet plaque formation due to coagulation system stimulation, and opposition of the uterine walls. All these things together will stop the bleeding, and that is the end of fourth stage of labor. If you find that the bleeding has decreased and the vitals are fine, her blood pressure and pulse rate, everything is fine, you know that patient is safe, and then you can actually stop the observation and you can send her to the ward. You can send the patient for observation in the ward wherever she will be recuperating until she is discharged. So it's very important for all of you to know what are the four stages, what are the events that are occurring in each stage of labor, and how do you monitor them. If you know the normal stages, you will be able to identify the abnormalities in each stage. So just to repeat, you know the stages of labor. The first stages are stage of cervical dilatation, stage of delivery of the baby, stage of delivery of the placenta, and stage of hemostasis. As simple as that. Coming to the first stage, what did we have? The onset of true labor pains. And how did you identify true labor pains? Because they were progressive in nature, they were having increasing frequency, intensity, and duration. They were associated with cervical effacement and dilatation. They did not subside with sedation or anemia, and they resulted in disadvantages. So following this, you had cervical effacement, that is the thinning of the cervix. It becomes shorter and shorter and shorter, it becomes papery thin. Also, the cervix became dilated, that means it started opening up from the closed cervix to full dilated cervix. And that resulted in expulsion of show. Show is nothing but a mucoid discharge between the internal and external os. It's blood stain. So presence of show means there is onset of labor. And once the cervix is dilated, there is no support. The bag of membranes are formed, and finally the membrane is ruptured and there's release. So as you saw that whenever the uterus contracts, there are two parts, the upper segment and the lower segment. This upper segment is very thick and muscular. Lower segment is thin and it just receives whatever is being pushed into it. So upper segment contracts, retracts, lower segment receptive relaxation. So in each stage, in the first stage, the upper part is contracting and pushing the baby into the lower segment. So this is cervical effacement, shortening of the cervix. Then dilatation. You saw the cervix is closed, opening up, each contraction further opening, finally 10 centimeters, fully dilated. So this dilatation occurs in two phases, early latent phase and later active phase where there is a phase of acceleration, very fast dilatation, then slowly it recedes. That finally leads to full dilatation of cervix. And you know when the cervix dilates, the blood here is expelled. This is the shock. Bloodstream discharges the shock. When there is no more support from the cervix, this bag of membranes is formed with a chorion and amnion. Few more contractions, this pressure increases and ruptures the thin membranes. So that rupture and the liquor will dissolve. That's the end of first stage. Primigravida 12 hours, multigravida 5 to 6 hours. Second stage, delivery of the baby. Here, the contractions of the uterus will cause the descent of the fetus continuously. It occurs in different stages. First, engagement, descent, flexion of the head, internal rotation of the head, extension. Once it comes out, untwist that internal rotation of the neck by restitution, and the shoulders will come in the anteroposterior direction and under internal rotation, which will be seen as external rotation of the head, and the shoulders are expelled. First the posterior shoulder, then the anterior shoulder. So once the shoulders come out, the rest of the body will pass through. Right. So this takes 1 to 2 hours in the primary, and in the multi it takes about half an hour to 1 hour. So it's always faster in the multi-gravity. Once the baby has come out, you have clamped the cord into places, cut in between, handed over the baby, you have the placenta inside. So you can see here the placenta is attached to the uterine wall, cord is seen hanging here. So again a fresh bout of uterine contraction will come because it will identify there's something still left inside, some foreign body is there. So it will contract again, and once it contracts, the wall is contracting, the placenta is not contracting. So there will be a shearing force between the two, start separating. And once it starts separating, the vessels will open up and there will be a fresh bout of bleeding. And because the blood will collect between the placenta and the uterine wall, the final height will increase slightly. And once the whole of the placenta separates, this placenta will fall in the lower uterine, which is seen in the picture at the height. And when the placenta is come to the lower segment, this cord will further come down. So it looks like a cord is lengthening, apparent lengthening of the cord. So fresh bout of bleeding, rise in the frontal height, suprapubic bulge, and lengthening of the cord. All four will tell you placenta has separated. And although naturally, if you leave it also, the placenta will get expelled by a few more contractions. We can shorten this phase by doing what is called traction, counter traction. You pull on the cord and apply the counter traction on the uterus. Once that comes out, you are left with the two methods I told you, the Duncan's method and Schultz method of separation. Duncan says when the lateral wall, the lower lateral end of the placenta comes out first, whereas in the Schultz method, it comes out like an inverted umbrella. So the shiny fetal surface comes out first. So it takes just about 15 minutes for either primary or a multi. In the fourth stage, you have the patient securing hemostasis by 4 methods. So you're observing whether this is taking place or not. So a good contraction of the uterus, spontaneous vasospasm of the vessels, formation of platelet plugs, and apposition of the uterine walls. All the 4 things will bring about a very efficient hemostasis. And that brings to an end of the fourth stage of labor. And then if all is fine, the patient vitals are good, you can shift her to the ward. So I want all of you to read this, make your notes on stages of labor, because this question is very, very commonly asked. If you have any doubts, you can put it in the group and we will try to answer you individually. Okay.